Hi, and welcome to this session on the cardiovascular system and blood pressure. So we've called this slide key reading. So on here is the Warren Grant textbook, which is key reading for this module, and also the Giddens textbook, which is about concepts-based learning in nursing. The other textbooks aren't essential, I'll just whiz through them very quickly. Blow's textbook is specifically about observations in clinical practice. Levick's textbook is quite hard, specifically about the cardiovascular system. It is quite a heavy textbook, but the reference is on here because I've used a number of diagrams from his text. Luff is a hemodynamic monitoring textbook, which is particularly interesting if you're interested in intensive care nursing, but again, maybe a little too technical at this stage. But there was a number of the slides that I've taken from Luff's textbook, especially around the history of the assessment of blood pressure. And then Marieb is a similar textbook to the Ross and Wilson key text for the module. So Giddens states that perfusion refers to the flow of blood through arteries and capillaries, delivering nutrients and oxygen to cells. Perfusion is a normal physiological process that requires the heart generate sufficient cardiac output to transfer blood through patent blood vessels for distribution to the tissues throughout the body. This links to previous sessions within this module and sessions still to come, in that it links with fluid balance, including things like osmotic and oncotic pressures. It also links with filtration and reabsorption. It links to cellular respiration because you need a good cardiovascular system or an intact cardiovascular system to manage cellular respiration and the need for oxygen and glucose around the body. It also links with the renal system because the kidneys will just not function without a good cardiovascular system. So we're going to focus on these three parts of Giddens' definition: the heart, the blood, and the blood vessels. So the blood is the fluid in the cardiovascular system. The heart is the pump of the cardiovascular system, and the blood vessels are the tubes to the cardiovascular system. This is very similar to a radiator or a heating system that you may have in your house or flat. So the fluid in the heating system is normally water with some chemicals added to stop corrosion. There's a pump, an electrical pump that pumps the fluid around the radiators to get the heat into different rooms of your house. And then there's some copper pipes, which are the tubes of the system. So a little bit of a history of blood pressure. So in the 1700s, the Reverend Stephen Hales measured arterial blood pressure in a horse by cannulating an artery in the horse's neck with a tube. And then in the 1800s, Posey, who is a French physicist, developed the U-shaped manometer and established the use of millimeters of mercury to measure pressure. In the early 1900s, Nikolai Korotkov, who was a Russian physician, developed the method that we still use today for non-invasively assessing blood pressure using a cuff on the arm. And then later in the 1940s, Peterson developed the invasive arterial line. So going back to the Reverend Stephen Hales' work, where you actually put a tube directly into the artery, normally in the wrist in intensive care units, to measure blood pressure directly from the artery. And then in the 1950s, Seldinger developed the method for inserting arterial lines. It's also a method that's used for inserting a number of cannulas within the body that you may see when you're out in practice. It involves inserting the tube over a guide wire once the guide wire had been inserted in via a needle. We'll go back to this idea that the cardiovascular system and blood pressure is related to a heating system in a house. So you have the pump, which is the heart, You have the boiler, which is where heat exchange occurs. So they're sort of analogous perhaps to the lungs where gas exchange occurs. You've got devices that can measure pressure, and that's the same in the cardiovascular system. There's a couple of areas in the body that can measure pressure and alter the tubes or the fluid or the pump to change the pressure. You've got a way of putting more fluid in, so that's be drinking, or if you're in intensive care or in hospital, using intravenous fluids. You've got a way of getting fluid out, so that would be passing urine, and the renal system, and then the radiators are akin to the organs of the body. So here is a picture, diagrammatic picture from that's from the Ross and Wilson textbook of the cardiovascular system, and it looks kind of like the analogy that we've used of the heating system in the central heating system we've used already. So blood pressure. Blood pressure is about the pressure exerted on the walls of an artery. So here are the walls of an artery, and it's the pressure that's pushing against those walls of that artery that is what we're wanting to measure. That pressure is pulsatile because the heart pumps rather than creates a flow of blood. It creates flow, but through a pump, and it has this pulse that moves down the blood vessel. There's the two numbers that you get with a blood pressure, the systolic blood pressure and the diastolic blood pressure. So the systolic blood pressure refers to the pressure created by that pump that pumps blood down the blood vessel. And that's that wave that you will get of a pulse moving down the blood vessel. And then diastolic blood pressure is the pressure that's within the system all the time in the background. So when the heart relaxes, that's diastole. And the blood vessels still exert a pressure on the blood to maintain a pressure in the background. If we didn't do that, every time you stood up, you would start to feel very faint and your organs would be underperfused. You wouldn't get enough oxygen through to your organs. So this is what the pulse pressure looks like as it's coming down the blood vessel. So the top of the pulse is the systolic pressure, and the bottom there is the diastolic pressure. And it's a really, really interesting waveform is this, and we may come on to this again in the future. But the top is the systolic pressure, the bottom is the diastolic pressure. The start of the upstroke, that notch where it just starts to go upwards, that's called the ancrotic notch. That's the point where the aortic valve opens and allows blood out of the heart and into the blood vessels, into the aorta and into the arteries. And then the upstroke there is related to how well the heart contracts. And then on the way back down, there's another little notch part way down between systolic and the diastolic pressure. And that notch is called the dicrotic notch. And that is where the aortic valve shuts. So here is a typical trace that you may see on an intensive care unit, where you have the electrocardiogram at the top, the SAT trace underneath, or the plethysmograph, the yellow line underneath, and then underneath that is an arterial blood pressure. And as you can see, that's that similar waveform again, with the ancrotic notch, the dicrotic notch, and the top of the wave is the systolic pressure and the bottom of the wave is the diastolic pressure. So what things have an impact on blood pressure? So to start with, the volume of the blood. The more blood that there is in the body, the more fluid that's on board, the higher the blood pressure. Also the contractility of the heart, how well the heart is functioning, will have an impact on, especially on the systolic blood pressure, but on the blood pressure and the flow of blood overall. And then the resistance to flow, and that resistance to flow is related to the viscosity of the blood, so how thick the blood is, but also the size and elasticity of the blood vessels. So if you're young and fit and your blood vessels are very dynamic, when you suddenly stand up, all your blood vessels constrict to maintain your blood pressure to your head, and you have a very dynamic system. But as you age, your blood vessels may not be as dynamic, and therefore when you stand up suddenly, you might start to feel a little bit dizzy. So blood pressure equals cardiac output times the resistance to flow, the systemic vascular resistance. Now, we talked about cardiac output earlier in the presentations in this week's information. And cardiac output equals stroke volume times heart rate. And we've talked about the stroke volume and what makes up stroke volume, and we've talked a bit about heart rate. So we can now expand those equations to say that blood pressure equals the stroke volume, the amount of blood that comes out of the heart in a single beat, the heart rate times the heart rate, which is the number of beats per minute, and then times the resistance to the flow of blood, the systemic vascular resistance. And these are all aspects that make up blood pressure. So, how is blood pressure controlled in the body? You may need to read a little bit more about this in the Ross and Wilson textbook, but we'll just do a quick overview of how blood pressure is controlled within the body. So, short-term control of blood pressure. So blood pressure needs controlling very, very quickly. If I were to stand up suddenly, I might not have enough blood pressure to push blood to my brain. So my body needs to react to that to push my blood pressure up so that I don't feel dizzy. So you have baroreceptors, which are nerve endings in the arch of the aorta and the carotid sinus, and it's sensitive to pressure. There are also chemoreceptors of nerve endings in the aorta and in the carotid body, is sensitive to levels of oxygen and to carbon dioxide and to pH, and they will change in reaction to that. There are also higher centres in the brain around emotion, anxiety, pain and anger. So if you're feeling particularly anxious at any time, that might have an impact on your blood pressure. The autonomic nervous system also changes the blood pressure, and the autonomic nervous system is divided into the sympathetic and parasympathetic nervous systems. So they are the fight and flight or the rest and digest systems. So sympathetic is your fight and flight, heart rate increases, increased contractility of the heart, and the blood vessels constrict to keep the blood pressure up, but also redirect the blood towards the organs that need it. And if it's fight or flight, then it's muscles that need the blood so that they can work quickly so that you can either fight or flight. Parasympathetic nervous system, or the rest and digest, reduces the heart rate and reduces contractility to rest and allows more blood flow to the gut, for example, to allow digestion to take place. So longer term control of blood pressure is controlled by the RAS system, or the renin-angiotensin-aldosterone system. It's also controlled by the release of the hormone antidiuretic hormone, or the name for that is vasopressin. And then finally, there's also an atrial natriuretic peptide, which is released as well to control blood pressure. But the main control in the longer term control of blood pressure is the renin-angiotensin-aldosterone system, which is worth spending a little bit of time getting your head around because it is quite complex. So what is a normal blood pressure? What do you think a normal blood pressure is? Have a think about that just for a minute. What do you think a normal blood pressure is? What have you been told? What have you potentially read in textbooks? So this diagram is from the Marieb textbook and shows the blood pressure, and the waves in that diagram where it says systolic and diastolic pressure there, those are akin to that waveform that I've showed you earlier. And in here it shows you that blood pressure decreases as you go from the aorta to the arteries, arterioles, and down into the capillaries. The blood pressure drops all the way through. You have to have a pressure drop to get flow of blood. You must have a pressure drop to get a flow of anything. So air, so when you get wind, it's moving from an area of higher pressure to an area of lower pressure. When you have a flow of blood or flow of water down a pipe, it goes from an area of higher pressure to an area of lower pressure. However, this diagram, it isn't quite true. It's quite simplified, and Levick offers us a slight alternative to that. And what Levick shows there at the top of the picture on the left hand side is that actually the systolic blood pressure goes up slightly. It goes up as it goes down the arterial tree, but the diastolic goes down and the overall mean blood pressure goes down, because you have to have that pressure drop to get flow. But the systolic goes up slightly, and the way that I would visualize that is like a wave coming up the beach. So the wave coming up the beach doesn't lose vast amounts of energy straight away, and what actually happens is the wave gets taller and taller until it then breaks. But just imagine the wave getting taller, so as the blood pulse goes down the blood vessel and the blood vessel narrows, the pressure, the difference in pressure, the systolic goes up, the pulse pressure increases as it goes down the blood vessel. And that's quite interesting. But then it drops off and the blood pressure reduces down all the way through until it goes back to the heart again, because again you have to have a drop in pressure to get flow. So this diagram is also from Levick's textbook and demonstrates blood pressure over a 24-hour period. And as you can see on here, the various spikes of blood pressure during the day, which is normal. You know, as you do something more, if you do something more physical, then your blood pressure may have to go up to compensate for that. But what's even more interesting is your blood pressure dropping quite significantly when you fall asleep, but still maintaining enough perfusion for your body to function. Another diagram from Levick's textbook which demonstrates that on average blood pressure increases over a lifetime, but there is evidence to show that blood pressure becoming too high will have a detrimental impact on the cardiovascular system. So we're just going to whiz through a few things that can have an impact on blood pressure. So we'll start with age. We've just looked at that graph and shows that on average blood pressure tends to increase with age. As you go, there's the distance along the arterial tree, and there's a little diagram coming up shortly and I'll refer back to that in a second. The vertical distance in gravity, so if you're standing up, then your blood pressure will have to be higher, and it will be, because of gravity, be higher at your foot than it is at the top of your head. Again, posture, by standing up, you have a gradient from the higher up, and it's also transient, so the blood pressure going up and going down as you stand up and sit down. Sleep tends to drop blood pressure, potentially as low as 80/50, which, you know, sounds quite low. And then physical activity of any sort will cause your blood pressure to go up. So the diagram there of the aorta and femoral pulse waveforms is about being the distance along the arterial tree, and it refers to the information that was in Levick's textbook that we looked at a couple of slides ago. So physical activity again increases blood pressure. Emotional input may increase blood pressure as well, so anger, fear, fight and flight. You can also get something called white coat hypertension, and that's where people have a blood pressure measured by a doctor or a nurse and they're quite nervous that it might be high, and that nervousness then it's the fait accompli that the blood pressure will then be high. A full bladder and the pain of a full bladder can put blood pressure up. The Valsalva maneuver, which is where you put pressure into your body against a closed epiglottis, so it's a bit holding your breath and pushing, is the Valsalva maneuver, will push your blood pressure up. Smoking, the various chemicals in smoke that you inhale in smoking has an impact on the nicotinic receptors in the body, which can cause vasoconstriction and push blood pressure up. And then losing blood from the system, so bleeding a lot, could cause your blood pressure to be quite low. And then finally, disease like hypertension, which can be caused by a number of different pathologies. So measuring blood pressure. Here's a picture of Nikolai Korotkov, who was the Russian physician who discovered and invented the indirect method of assessing blood pressure by placing a cuff around the arm and occluding the artery within the arm, and then allowing the flow back in really, really slowly and listening to when that flow comes back in. So here's a picture of that system. So the cuff occludes the artery. You then allow the air back in, like back out of the cuff. So you pump air into the cuff to occlude the artery, allow the air out slowly, reducing the pressure, and then gradually the pulse will come back through. But in the first instance, it will come back through quite turbulently, and you'll listen for that turbulence in the blood vessels, and that they're called Korotkov sounds, and it's listening to them starting and then noting when they stop. And that's how you measure blood pressure. There are other videos on the VLE which will show you how to do that. Just to get your head around blood pressure, please read all of the indicated reading for blood pressure, both in this module and also in the Knowledge and the Skills Applied to Nursing Practice 1 module, especially prior to the practical session that we hope to do at some point in the future. So the procedure for taking blood pressure is first estimate the systolic pressure, and you do that by putting the cuff around the arm, inflating the cuff whilst palpating the artery, and then estimating when the pulse in the artery stops and what that pressure is. You then let the cuff down and pause for a moment just to let the arm recover. You then re-inflate the cuff to 30 millimeters of mercury above the estimated number that you've just got. You then deflate the cuff slowly at about 2 millimeters of mercury per second, nice and steadily reducing that pressure. And you listen over the brachial artery, and then you identify where the soft sounds of the Korotkov sounds come in, and then they get louder, and occasionally you have a gap. You have something called an auscultatory gap where it stops for a moment, but then it comes back in again, and then eventually it stops. And so it's where it starts and where it stops that you measure blood pressure. And if you watch some of the other videos that are on the VLE, I've recorded some videos where you can hear those Korotkov sounds. The Korotkov sounds have been defined as so that they start faint, and then it can soften, possibly create this gap, and then it return with a sharper sound, and then a distinct muffling, and then it stops. So those are the phases of the Korotkov sounds that you listen for when taking a blood pressure. And just to reiterate, it's when the first sound starts and when the final sound occurs and it finishes, obviously where you take the two readings. That's the systolic over the diastolic blood pressure. The system using a cuff over the artery isn't perfect, and there are loads of different reasons why you may incorrectly estimate a patient's blood pressure. So if the artery that you're measuring the blood pressure in is well below the heart, then you'll get a high reading. If it's above the heart, you get a low reading. If you don't have the right size cuff, it can affect having an incorrect reading. That's either too long, too short, or too narrow. If you don't estimate the systolic blood pressure, then you might pump the cuff up and listen and hear the auscultatory gap, thinking that's the sound coming in after the auscultatory gap is the systolic blood pressure, and it's not. If you deflate too fast or too slow, that can create a high reading. If you don't rest in between inflations, that can create high reading in the patient as well. If the patient's legs are crossed, that's going to affect the flow of blood and will shunt blood. It will push blood to other parts of the body, including the arm, and put the blood pressure up. And also an unsupported arm, your muscle will be tense in the arm to hold the arm up. And then things like tight clothing can have an. So hopefully when we get to the CSU, remember to wear appropriate clothing so that we can do blood pressures on each other and then practice that skill. So to summarise, we'll go back to what Giddens says in her definitions of perfusion. Perfusion refers to the flow of blood through arteries and capillaries, delivering nutrients and oxygen to cells. Perfusion is a normal physiological process that requires the heart generate sufficient cardiac output to transport blood through patent blood vessels for distribution in the tissues throughout the body. So remember the three key points in there that I highlighted earlier: the heart, the blood, and the blood vessels. So that is the fluid, the pump, and the tubes of the cardiovascular system.